Hello, sir. Ramesh, sir. Ramesh,
Hello,
sir, am I
Matthew.
on?
Good evening. How are you?
Good evening, sir.
So, how are you? Nice to you.
Yeah. Uh,
Sir, namaste.
Good evening.
Good evening, sir.
Now, Lakshmi, how are you?
Okay, sir. Fine, sir.
People are just joining in.
Sir, VG Ramesh sir is all our guru on NPH, sir. Sir only, the intracranial pressure measuring and all, we never knew. Sir only taught me as a student.
Yeah, sir.
I never forget that. Thank you.
I just read this publication just now.
Yes, sir. So happy to see VGR, sir. Thank you.
Oh, thank you. How do you find Ramchandra?
Sir, very, very busy and stressful, sir.
How do you?
Too many VIP.
Oh,
No, sir.
more than GH, eh?
Sir, more than GH. Because both Tamil Nadu and Kerala VIPs, the Andhra VIPs, both Tamil Nadu and Andhra.
Oh.
It's all, they have a lot of links. Most of them are all, I'm seeing most of the cine celebrities or most of the big people, they get admitted this. Sir, handling two chief minister and the Andhra chief minister also comes only here. Chief minister and the farmer, everybody comes only here.
I see.
They have very, very wide network, sir.
Okay.
More than that, they have one full floor dedicated to international patients.
Oh.
So,
hello, Suresh. Good evening.
Sir, Ramesh sir, would you like to check your slide?
I checked, sir. I also want to just 1 second. I'll check, sir.
Yes, sir. Please share. Yeah, it's seen very well.
Visible, sir?
Yeah, visible. No problem.
1 minute. So I'll just make it full screen. Is it okay, sir?
Yeah, perfectly okay.
Sure. Thank you.
Perfect. Thank you.
I'll stop sharing, sir.
Ramesh sir?
Yeah.
Ramesh sir, can you try your slides, sir, whether they are working?
Hi, Matthew.
Hi, sir.
How are you?
We have 3 minutes more, sir.
Yeah, no,
your slide is visible. Your slide is quite okay, sir. Ramesh sir?
Yeah.
Slides are visible, sir.
It's okay?
Okay, sir.
It's okay?
Yeah, they are running well. Okay.
Yeah,
right. I'll stop sharing.
Hello, sir. Our Dhaval Shukla has a small delay. He will join within an hour, before 5
Okay. Hello, Dr. Bansalji. Good evening.
Sir, good afternoon.
Good afternoon, yeah. Dr. Suresh, how are you?
Yes, sir. Very well, sir, very well. You look so young. Good.
Bansal, sir.
Yes, sir. Hi, Matthew. Good afternoon.
Hi, sir. Good afternoon. We have
How
2 more minutes, sir. We'll start correctly on time,
yeah.
sir.
So, will you introduce or should I introduce?
Sir, I will welcome people and welcome everybody. And then you can introduce the topic first. Then I will introduce the speakers. Then you can introduce the panelists and initiate the discussion. So initially, I will just welcome. I'll introduce you as well as the, and then call you to introduce uh, the topic, the subject.
Mhm.
Hi, Bansal.
Hi, good
You could have
afternoon.
done this webinar from Chennai also.
I'm in Chennai only.
Oh, you're in Chennai only? Yeah.
Yes,
I'm
sir.
at airport then. I
Are
just
you
left.
coming or going back? Coming or going back?
Going back
Sir
to
is
Bombay.
leaving.
I came on Thursday actually, Thursday morning.
Oh, I just arrived afternoon after Sumit's conference from Delhi,
Yeah,
Okay, okay.
I
just
understand.
before lunch.
Sir, good
Okay.
evening, sir. Good evening, sir. Actually, Dr. Matthew sir and Bansal sir will take over the webinar, sir, because I'm traveling. So I hope it will be a group program, sir. Matthew sir and Bansal sir, kindly take over, sir.
Okay.
Yeah,
Perfect.
we'll do. You carry on.
Yes,
You
sir.
carry on,
I
Kodishwaran.
think
Yes,
we
sir.
have
Yes,
just
sir. Thank you, sir.
reached. It is just time.
Thank you, sir.
I think we will start.
Yes, sir. Please, sir.
So, good afternoon, everybody. Welcome to this session of NSI webinar. Today's topic, as you all know, is normal pressure hydrocephalus. And we
Matthew,
are one
how
of
many
the,
people have joined? How many people are there?
we have
Still
15 people
15.
who have joined.
15. Okay,
That will
it's
quickly
good.
increase. That will quickly. Now, this is one of the most vexing problems that all neurologists and neurosurgeons face. And we have one of the best panels to discuss this topic. Let me first introduce my co-moderator. There is Dr. Bansal. Dr. Bansal is, Dr. K.K. Bansal is an NSI executive member. He is currently senior consultant neurosurgery in Narayana Hospital, Jaipur. Formerly, he was professor at the Himalayan Institute of Medical Sciences at Dehradun. He is a Sugita scholar, and he is a Union of International Cancer Control Fellow, and he has a Sick Kids Hospital Tumor Fellowship. Over to you, sir, to introduce the topic.
Yeah, thank you, Matthew. We too are moderating this session, and today our speakers are well-reputed people from, first of all, we have divided the topic. The topic is actually normal pressure hydrocephalus. As Dr. Matthew has said that this is currently increasing in number, this problem. As we are getting the aging population in our country, there are two big problems are going to we are going to see more and more weak clinicians. One is NPH and another is the chronic subdural hematoma. So we are going to these numbers are going to increase day by day as the population is aging. So today's panelist is Mr. Dr. Professor Daljit Singh, who is emeritus professor at GB Pant Hospital. He was the president of NSI, and he had so many this thing on his name, lot of articles, and a very good and renowned neurosurgeon from GB Pant. And the another panelist is Professor Dr. Hemant Bhartiya, who is a very fantastic surgeon, and he is a senior consultant at Fortis Hospital, Jaipur, and he is the chairman there, and he is organizing many conferences in the past also. One of that the NSI, he did it in 2018 and 2017. He did the endoscopy conference, and then last year he did the meningioma international conference, and as well the cerebrovascular society conference. So he has a very good interest in the endoscopy and the vascular surgery. And Dr. Daljit Singh is also doing a lot of endoscopy at GB Pant. So today's speaker, you are going to introduce, should I keep on telling?
So our first talk for the day is NPH clinical features, mimics, and DD. And our speaker is Dr. Lakshmi Narasimhan. Dr. Lakshmi Narasimhan does not require any introduction to this audience. He's one of the most prominent figures in neurology in India. He's currently professor of neurology at Sri Ramachandra Medical College at Chennai. Formerly, he was director and professor of neurology at the Institute of Neurology, Madras Medical College. Uh, he has a PhD in neurology and also has an FRCP from Glasgow. He's president of the World Headache Society. He's president-elect of the Indian Academy of Neurology. Uh, the most popular textbooks in neurology like De Jong, Paul Dreyfus, and Hiller, he has been the editor for these. And he's a recipient of the Atlas, the Patilusi, and Abbaker Best Teacher Awards. He's a recipient of the Distinguished Teacher, Mayan, and Dronacharya Awards. He's extensively published. He has more than 100 articles. He's delivered several orations. He's also editor of the International Journal of Epilepsy and the Journal of Stroke Medicine. He's the editor of the Cochrane Epilepsy Group. Over to you, sir. NPH clinical features, mimics, and DDs.
Thank you, sir. Thank you so much. Thank you. I'll share my screen. Is it visible, sir?
Yeah,
Yes.
obviously.
See, thank you for such a generous introduction. I'm so kind of you, and it's always when you talk in front of your teacher, Professor V.G. Ramesh, you always become, it's like sitting in the viva in front of your examiner. It's always, so a man I always rate Professor V.G.R. as a genius in the Institute of Neurology, who has taught with so much of passion, he taught all of us. Thank you for giving me this opportunity. I thank thee. In 1971, the Margagni described 3 cases of chronic senile hydrocephalus in subjects more than 60 years. The clinical syndrome of NPH was then not known. Later on, Solomon Hakim and American neurologist Raymond E. Adams, they formed the Hakim-Adams syndrome. The clinical features, great variation in onset, severity, and progress. Cardinal symptoms is the classical Hakim's triad of gait disturbances, dementia, and incontinence. All of them need not be present together and actually appear at different times. The symptoms when present usually tend to be progressive, which varies from stable course over several months to rapid deterioration over few months. What happened is recently, after the advent of lot of newer evaluation techniques like pressure sensitive platforms, optoelectronic motion capture systems, variable inertia sensors, the evaluation of gait in NPH is completely changed. And the typical onset of an IPH in the elderly population, they appear earlier. The patient should definitely be at least 40 years to have a probable diagnosis of idiopathic NPH. Average age is around 70. Both men and women are equally affected. Prevalence is 0.2 and 5.9 beyond 80 years. And you can see that the overlapping, all the 3 symptoms together present in only 48%. And you can see the differing dementia alone is 2%, gait alone, different combinations can happen. The most common presentation which is seen almost every case, either alone or in combination, is the gait. Typically, the first symptom thought to be represent gait apraxia. The decreased gait velocity and cadence with shorter and more variable strides. Step height is reduced and the dorsal extension of the forefoot is insufficient. Patient may shuffle, may be glued to the ground like a magnetic gait. The gait is atactic and broad-based. When perturbed, the patient may lose balance. Problems when patients begin walking or when turning or freezing. The examination part, as I told you, is assessment of this magnetic gait, 10 meters gait, timed up and go tuck test, the Trinity gait test, and the 6 feet walk test. And as I already told you, this optokinetic, the kind of motion sensors, the kind of all these things add a lot of input to this. Particularly, what you should look for is an externally rotated posture of the feet. In contrast to Parkinson's disease, the take-home pearl is this. Patients' normal pressure levels have preserved reciprocal arm swing with a balanced directed posture and backward directed posture and a tendency to fall. So what you have to look for is, even though the gait mimics Parkinson's, but the preserved reciprocal arm swing is retained in NPH, but it's very early to get lost in PD. And the early stages of idiopathic NPH, the gait disturbance is subtle. Patients often complain about this subtle gait disturbances or problems. They sometimes tell it is dizziness. In late conditions, apraxia of the upper limb may also occur. Coming to dementia, the idiopathic NPH corresponds to a frontal subcortical dementia. The psychomotor slowing, apathy, affective indifference, inattentiveness, and memory deficits. Intellectual ability seems to be present, but in a sleepy, blurred condition with loss of spontaneity and communication. Patients sometimes akinetic mute. And neuropsychological evaluation should include tests that major domains like attention, memory, executive functions, visuospatial skills, psychomotor and motor skills in mood, and other psychological functioning. And these parameters tend to improve following a large volume CSF test. The differentiating dementia from idiopathic NPH, the other cause of dementia, may be difficult. More than one pathology can coexist in the same patient, and primary dementia syndrome can rarely mimic the radiological features of NPH and can also show transient response to CSF tap. So, in fact, there are many number of times people have burnt their fingers by treating the cases as NPH, and autopsy finding have turned out to be many times it is turned out to be different. Coming to incontinence, extremely rare to have incontinence as a major and only symptom of NPH. Urinary urge is more important, urinary frequency and urinary urge found towards the onset of the disease. The gait disturbances may accentuate the urgency, impeding the ambulation. In advanced stages, complete urinary incontinence, even fecal incontinence may be present. Being a cortical pathology, NPH is not generally associated with the increased post-voidal residual volume. So if it's just for PVR, there is no residual volume. It's more likely to be the central pathology. Pathophysiologically, the bladder function is a sequelae of detritus or I don't want to go into the pathogenesis zone. The subsequent speaker is going to talk on that. Incontinence without awareness of urinary urge or that one's clothes is wet is not observed. So you should know the patients invariably they are aware, invariably they have urge, but the urge incontinence is more common than. So the pearl is incontinence can be seen in variety of dementing illness. However, in idiopathic urinary incontinence is very early in the course of illness, unlike other dementias. Similarly, post-voidal residual volume helps differentiating these cortical causes of incontinence from the others. I'll show you that this is a timeline you can see in other dementias. Whereas this in multi-infarct dementia, it is 5 years preceding the illness you get the incontinence. In Lewy body, after the onset of dementia, 3 years after the onset, you start getting the average start of incontinence is 3 years in Lewy body, whereas in Alzheimer's is about 7 years. So, typical characteristics of NPH: atactic, broad base, slow, short step size, magnetic gait and shuffling, preserved reciprocal arm swing, and preserved the magnetic gait and shuffling. Typical signs of mental: psychomotor slowing, apathy, affective indifference, inattentiveness, memory impairment, high urinary frequency, urinary urgency, complete urinary incontinence, fecal incontinence is rare. Coming to headache, some authors have suggested neglect headache, but others consider headache to be an important. A lot of controversies in this. Usually felt as pressure in the head. Prominent headache should prompt evaluation for an alternate pathology. Dizziness, most often the apraxic patient, they have complaints of dizziness, balance disorder, subjective and sensational gait apraxia, and the fear of falling. K4 grading scale importance to both. Now, even here, you will be surprised that the posturography in measurement of various indices, the posturography indices like the sway index in on pillow, it's called foam with eyes closed, foams with eyes open, and feet eyes closed, feet eye open. The feet eye open and feet closed posturography would give about Romberg's, and the foams would give the vestibular component, and all these things you see, the graphs will give the characteristic types of graphs in posturography in NPH. They can either coexist with NPH or develop as a psychiatric features can coexist, or as a consequence of NPH, depression mania. Literature mentions case with idiopathic NPH, psychiatric features are resolved, however, not being reported. Extended need for sleep. Several reports have mentioned that these patients, idiopathic NPH, have a significantly longer period of time compared to healthy controls. Many hypotheses have been posited to explain this. Dementia with missing impulses, interest with hence boredom. Some studies link sleep-related disorders to a cause rather than the consequence. Large head circumference compared to healthy control suggests your developmental disorder contributing to NPH, impaired sexual dysfunction. Issues in no combination of cardinal signs are pathognomonic. Each of the cardinal symptoms is common and hereditary and multifactorial. All diagnoses have significant false positive as false negative. Surgical treatment associated significant short-term as well as long-term risk. Exact pathogenesis is elusive. And if you look at the grading, Stein-Langford grading, which is 1 to 4, no neurological, minimal deficit, supervised equation, custodial care, and no practical capacity independent function. The Black's classification, again, 4 mild, moderate, and severe. The IDES classification, where it is classified as gait, is based on all the 3. Gait is classified into 5 stages. Dementia is classified into 5 stages. Urinary disturbance is classified into 5 stages. If you look at the Black's classification, except for the first gate, mild, moderate, all the urinary incontinence is compulsory. And in moderate, if you still look at it, the severe form, they are disoriented. Otherwise, the memory difficulty is mild. Coming to the Hellstrom's grading, which is it's very complicated. I don't want to go into the detail, just to the students to know that gait, balance, and psychological studies and continence are evaluated independently. And based on this, you arrive at what is called an NPH scale, which is equivalent to 2 into gait plus neuropsychology plus balance and continence scores divided by 5 or number of domains which you have taken. So this is the scale which is being used for the NPH management. Coming to last part of my talk, and mimics, 73-year-old man exhibited false visual hallucinations, irritability, and combative behavior. 2 months he was unable to ambulate independently and noticeable memory loss. Brain MRI taken at 3 months from symptom onset demonstrated moderate ventriculomegaly without any overt atrophy. Later developed dysarthria, anarthria, and severe. At 5 months showed heteropolis, axial prominent rigidity, and ophthalmoplegia. Cognitive assessment is impossible. At that point of time, they thought it is PSP. Cognitive assessment is impossible given marked dysarthria, early progression, death from aspiration pneumonia, ventriculomegaly with increased Evans index, no significant white matter abnormalities, no obvious cortical atrophy, minimal rostral. So the clinical diagnosis is PSP, and which is supposed to be, but what exactly happened? The postmortem biopsy revealed features suggestive of DLB, BRCA5 likelihood. So all these things are essentially overlapping, and high degree of clinical suspicion is needed for diagnosis. And more than that, even a therapeutic tab can give benefit in both in non-NPH cases. Also, they show some improvement. So it's a very tricky situation. Diagnosis of NPH can be sometimes troublesome, not straightforward. People tend to overdiagnose it. And NPH mimics. We look at the gait, Parkinson's, lumbar canal stenosis, cervical myelopathy, arthritis, cognitive dysfunction, any dementia syndromes, and depression, and urinary dysfunction, drugs, infection, prostatism, stress, incontinence, or pelvic floor laxity, gait dysfunction, like NPH, arthritis, spinocerebellar degeneration, disease, dementia, AD, FTD, depression, hypothyroidism, sleep apnea, B12 deficiency, and NPH, Parkinson's, vascular dementia, incontinence, prostate. So this is in summary of the various mimics. Common things to summarize this: secondary normal pressure hydrocephalus, chronic obstructive hydrocephalus, Parkinson's, Alzheimer's, Binswanger's with the cerebral small vascular disease, brain atrophy, cervical myelopathy, lumbar canal stenosis. What is secondary NPH? Is pre-existing condition that could interfere with cerebrospinal reabsorption, such as meningitis, subarachnoid hemorrhage, or traumatic brain injury. If the aforementioned disorders were of moderate intensity or happened several years prior to the presentation, it is unclear. Clinical features as such do not differ, offer any major clues to differentiate idiopathic NPH from secondary NPH or other forms of chronic obstructive hydrocephalus. All 3 disorders can be associated with a combination of these 3. So what differentiates them is idiopathic incontinence. The gait disturbances, incontinence, dementia are present. No history of SAH, STBA, meningitis, or brain surgery. Imaging of CS pathways obstruction is not there. In secondary, you will see history of a subarachnoid hemorrhage, TBI, meningitis will be present, or brain surgery. The imaging does not show any obstruction. In chronic obstructive hydrocephalus, all the 3 is present. So red flags: cognitive impairment that predates or occurs concurrently with gait dysfunction, prominent postural abnormality, Visual hallucination is a red flag. Supranuclear ocular motor abnormality is a red flag. Urinary complaint that significantly predates years after the cognitive impairment is a red flag. Features of cortical dementia like apraxia, aphasia, agnosia, and apraxia are again red flag. Gait ataxia that worsens with eyes closed is a red flag. LP, difficulty in performing LP when the patient suspected to have NPH. Increased CS of opening pressure is a red flag. Age less than 10 is a red flag. And transient symptoms, lack of progression of symptoms, presence of bulbar or pyramidal cells. Thank you for your attention. I stop sharing here.
Thank you, Lakshmi Narasimhan sir, for an elaborate talk. And we will have the discussion at the end. Our next speaker is Dr. Ramesh. Professor V.G. Ramesh is currently Professor Emeritus, Department of Neurosurgery, Chettinad Hospital and Research Institute, Chennai. He's one of the senior most neurosurgeons in the country with more than 4 decades of neurosurgical experience. He has been an examiner in almost all the institutes and medical colleges in the country. He has several publications in neurosurgery journals and authored chapters in textbooks. His major contributions include the Madras Head Injury Prognostic Scale, the Madras Institute of Neurology method of CSF outflow resistance measurement. So he's somebody
Can't hear you.
I think Matthew is out of line.
Can't hear him, no?
Matthew, I am not able to hear you.
Somebody will have to call him.
We can hear you, Professor.
You can
Hello?
start, Professor Ramesh.
Yeah.
Yeah, Professor Ramesh, we can hear you. You can start.
Okay, I will start.
Start your presentation, sir.
Yeah.
Yes, it's coming.
Yeah. Good evening, everyone. And today I am going to talk about pathogenesis of normal pressure hydrocephalus and CSF fluid, CSF dynamic studies in the diagnosis of normal pressure hydrocephalus. Lakshmi Narasimhan has nicely elaborated on the clinical features and also touched upon various pathological substrates for the symptoms. I am going to talk about modern.
Come back.
Again, you are on for remote only, sir.
No, I have to switch off. Completely
Dr.
keep
K.K. Bansal. Dr. Bansal, you have to mute your mic if you are. You have to mute your mic if you have to.
Yeah.
You can't listen.
Okay, sir. Sorry, sir. Sorry.
Okay, I'm going to talk about the pathogenesis and CSF fluid studies in normal pressure hydrocephalus. I'm going to talk under the following headings like CSF physiology, then what is the pathogenesis, basic science basis for normal pressure hydrocephalus, and diagnostic methods in diagnosis of CSF, then CSF dynamics studies also, and also briefly touch upon our improvised technique of bolus lumbar infusion method. As everybody knows, the CSF physiology, the CSF formation is by choroid plexus and forms 80 to 90% of the CSF production at the rate of 0.3 to 0.5 ml per minute, and about 500 ml is produced per day. The circulation is the conventional foramen Monro, lateral ventricle, foramen Monro, third ventricle, aqueduct, subarachnoid space, and superior sagittal sinus, and absorption is through the arachnoidal villi along the superior sagittal sinus, governed by the pressure gradient. This diagram shows the various production sites of the CSF and the arachnoidal villi, and then the various pathways of the CSF. Now, recently, the CSF physiology has undergone some modifications, and with the discovery of alternate sites of CSF production, namely, even the ventricular walls and arachnoidal membrane are supposed to produce CSF. Normal ventricular ependyma also is producing some amount of CSF. And also, there is now interest on the glymphatic pathway. I will touch upon that a little later. And CSF circulation has been modified with the advent of the glymphatic pathway. And there has been alternate sites for CSF absorption, like this nasal cribriform plate, or spinal perineural lymphatics, and this subarachnoid space, of course. So now the recently discovered lymphatic system has shown that there is perivascular, this previously called Varsho-Robin space, the perivascular space, and there is accumulation of CSF, and then it is absorbed by the CSF is absorbed by the aquaporin granulated channels to the astrocytic perivascular end feet, and this promotes clearance of excess of fluid and waste metabolites from the CSF. Normal glymphatic system relies on appropriate pulsation of the brain and the vascular pulsation, and also the intact aquaporin channels, and without sleep apnea, obstructive sleep apnea. The classical theory for pathogenesis of hydrocephalus has been that there is an absorption defect by the arachnoidal villi. That has been the current theory, and it has been held for a long time. The recent studies have concentrated on the glymphatic pathways in the pathogenesis of normal pressure hydrocephalus. The recent Chinese paper from China has highlighted this in the pathogenesis of normal pressure hydrocephalus. They advocate that the excess of CSF might stagnate in the dilated perivascular space, which compresses on the penetrating arteries to reduce the pulsatility of the arteries. And there is a decreased aquaporin 4 density in the astrocytic perivascular end feet, and progressive aquaporin 4 depolarization with aging further exacerbates the abnormal perivascular fluid flow in the aged NPH patients. And sleep apnea could promote overnight accumulation of metabolites in the interstitial space, and repeated inspiratory movements against the tongue-blocked airway leads to elevated intrathoracic pressure and reduced venous pressure return, and which ultimately causes venous hypertension and normal pressure. This is one of the recent theories postulated for the pathogenesis of hydrocephalus. So, as Lakshmi Narasimhan said, the pathogenesis is still fully not understood, but only partially understood. So the diagnosis depends on the clinical features, imaging, and the MRI, phase contrast MRI, and also the CSF dynamics. The clinical features, as Lakshmi Narasimhan has already elaborated upon, the clinical triad with the gait disturbance more predominant than the cognitive impairment is supposed to be diagnostic of normal pressure hydrocephalus, with the exceptions what Lakshmi has told. And imaging, the ventricular enlargement out of proportion to the atrophy, aqueduct flow wide, crowding of sulci in the higher cuts, narrow callosal angle, and periventricular hyperintensity are suggestive of normal pressure hydrocephalus. See, you are seeing the various radiological features showing the ventricular elevated Evans index, periventricular lucency, and also the flow void in the aqueduct. And also now we are seeing the narrow callosal angle with the crowding of sulci in the higher cuts. These are supposed to be radiological features which can help in the diagnosis of normal pressure hydrocephalus. CSF studies are also useful in the diagnosis when the clinical features and radiological features are equivocal. And also these are also used as adjunct tests for the diagnosis or confirmation of diagnosis of NPH. One of them is these are the ICP monitoring, external lumbar drainage, CSF tap test, and CSF dynamics study, which that is outflow resistance measurement. Out of which ICP monitoring and external lumbar drainage are not frequently employed because of the complexity. But CSF tap test is routinely employed by most of the people, and the CSF dynamic studies are also useful in diagnosis when the CSF tap test is equivocal or not suggestive of NPH. Among these, the of 4.4 to 17.6 millimeters of mercury is suggestive of idiopathic IPH. Warping pressure more than 17 is diagnosed indicative of secondary NPH. And in the ICP monitoring, the presence of A waves and B waves more than 20% of the record or diagnosis of NPH, but it is of no value in predicting shunt responsiveness. But it requires hospitalization and invasive ICP monitoring. These are the little, not acceptable for most of the people. And CSF tap test is doing lumbar puncture and removal of 30 to 50 ml of CSF and assess for the improvement in gait. And some people use neuropsychological evaluation before and after the tap test. It is very simple to perform, easy to perform, and it is good diagnostic yield for NPH. So specificity is 33% and sensitivity is 62% in predicting shunt responsiveness. External lumbar drainage, continuous external lumbar drainage is used by some people. Placement of intrathecal lumbar catheter, controlled drainage of CSF about 10 ml per hour for about 48 to 72 hours, and assessment of for gait improvement and neuropsychological improvement. Shows better predictive value than the tap test, but the patient needs to be hospitalized and has more incidence of complications. So it is not usually performed. The CSF outflow resistance measurement is gaining importance in the diagnosis of NPH and prediction of some responsiveness, especially when the CSF tap test is equivocal, or even if the opening pressure is not very suggestive of NPH. So these are the situations where the outflow resistance measurement helps in the diagnosis of NPH. There are two methods, commonly employed methods for CSF outflow resistance measurement. One is the constant flow infusion method of Katzman. It is also called Katzman's method. The other is the bolus lumbar infusion method, which was devised by Anthony Marmorov. And they have little modified the Marmorov's method with the improvised method using easily available material, which I will elaborate later. In Katzman test, the constant infusion method, the pump introduces saline at a known rate through a needle placed in the lumbar subarachnoid space. The R out is the difference between the final steady state pressure reached and the initial pressure divided by the infusion rate. But this method is time consuming because the plateau to reach the plateau, it takes a long time. So, and it needs a special laboratory setup to perform this test, though it is more accurate than the bolus infusion test. The bolus infusion method devised by Marmorov involves injection of known volume of CSF into the subarachnoid space, and it is calculated using two-step formula. It is less time consuming And also method measures the compliance of the brain. And also you can measure the pressure volume index using this method. The Madras Institute of Neurology method, which we have devised in the Institute of Neurology, which Lakshmi Narasimhan also cited earlier. We use a easily available material in the hospital. No need special setup is required. So we call it improvised method, and it can be done on the bedside itself. Can be done within a few minutes, and no expensive material or equipment or laboratory setup is required for this method. This is the thing which is required for doing. These are the few things. I mean, intravenous stand. If manometer is not available, you can. I used to stick the measuring tape to that stand and use the intravenous infusion set itself. If a manometer is available, you can use the manometer, and three-way adapter and the lumbar spinal needle. And if you have the calculator, you can use the calculator, or you can use the Clark's table for calculating the outflow resistance. It's a little bit. Only the problem is the calculation of it. It involves a lot of mathematics. This is a setup. You do lumbar puncture, and a saline manometer is made using the intravenous stand, or if it is readily available, you can use that. And zero level is corresponding to the level of the spine. And lumbar puncture is performed using 20 gauge spinal needle connected to saline manometer through a three-way adapter. After the CSF column stabilizes, the opening pressure is noted. The known volume of CSF, saline, usually 5 or 10 ml, is injected in the subarachnoid space through the three-way port at the rate of 1 ml per second. The peak pressure reached after the after the bolus infusion is noted. Once the saline column in the manometer starts falling, after a fixed time of say about 5 or 10 minutes, the pressure recording in the manometer is noted. So with these values, that is the opening pressure, then the peak pressure, then the pressure which after a time interval, and the volume of CSF, and the time taken for the measurement of the final pressure are noted. These are two-step formula is used. First step, you measure the pressure volume index, and second step, we measure the outflow resistance, CSF outflow resistance. And it gives the value in centimeter of water, can be converted to millimeters of mercury per ml per minute, and divided by 1.36. Normally, I have found that the normal CSF outflow resistance in Indian population has been between 6 and 9 millimeters of mercury per ml per minute. And we did a small study which we had published, and maybe I have done more number of cases now. I have been using it regularly now, and many of my colleagues are also using it. The study which we did, then we involved 19 patients, and we considered a value of 18 millimeters of mercury per ml per minute was diagnostic and predictive of shunt responsiveness in normal pressure hydrocephalus. The prediction of shunt responsiveness was accurate to 87.5%. This is the publication which I have done in the journal, and to quote a case example, a 45-year-old man presented with gait disturbance and memory disturbance of 8 months duration. Neurological examination revealed that he had moderate degree of cognitive impairment with memory deficits and slow ataxic gait. CT scan showed a moderate degree of cortical atrophy and ventriculomegaly, and the diagnosis was not very certain. CSF opening study, opening pressure showed 17 centimeters of water, which was only a mild elevation. And our outflow resistance measurement showed that the value was 22 millimeters of mercury per ml per minute by our Madras Institute of Neurology method. And clinched the diagnosis of NPH. After the shunt, patient's cognitive impairment and gait improved remarkably. This is the consensus which appeared in the Neurosurgery Journal in 2005. Proceeding with the infusion test directly after the TAP test will be highly sensitivity ranging from 57 to 100% and is associated with sensitivity of specificity of 75 to 92%. It can be done in an outpatient clinic. The highest sensitivity and highest positive pressure predictive value was associated with external drainage but requires hospitalization. So this is the algorithm they mentioned in that this thing consensus report. To conclude, the understanding of CSF physiology has undergone sea change with the discovery of glymphatic system. The concept of pathogenesis and pathophysiology of NPH are also changing. The diagnosis of NPH is mostly on the clinical and imaging findings, complemented by CSF flow studies. CSF studies are good adjunct to the diagnosis of NPH in predicting response to shunt. CSF opening pressure, outflow resistance measurement, TAP test are all equally good tools. ICP monitoring and external lumbar drainage have their limitations. Outflow resistance measurement predicts shunt responsiveness more accurately. Madras Institute of Neurology method is a very simple bedside tool for the measurement of CSF outflow resistance measurement. I thank you all for patient hearing, and I welcome any comments or questions. Thank you.
Thank you, Ramesh sir, for elaborate talk and for giving new insights into this topic. I have a feeling that Dhaval Shukla has not yet joined. So maybe he may be able to join a little later. I'm getting some information that he may join at 5 o'clock. So maybe we can start the panel discussion. Bansal sir?
Yeah, can we invite
Yeah, I
Dr.
think we can
Bhartia
start the
and
panel. The panelists can actually initiate the discussion. Daljit sir is.
yeah, Dr. Bhartia is already there, and I don't see Dr. Daljit Singh. Is he here?
Daljit Singh is also there.
Yeah,
Daljit
he
sir
is
is
also
also
here. Yeah, Daljit sir is also
there.
here.
Daljit
So,
sir? Yeah, he's also there. Both Daljit Singh and Dr. Hemant Bhartia are there. We can start off with.
Dr. Bhartia can start the discussion, and then Dr. Daljit Singh can also continue. You, Dr. Bhartia, please unmute your phone.
Yes, yes, I have unmuted the
Sir, Daljit Singh,
phone.
sir.
Yeah, I am here, very much here.
Yes, sir. We can have a panel discussion on the normal pressure hard of class till the
Okay.
Dr. Dhaval Shukla is probably I think is in OT, and he will be joining very soon. And till then, you can have a panel discussion.
Okay. So, let me ask the first basic questions. Beside, how do we rely completely on TAP test? Are we relying only on the gait improvement, or we do rely upon some other parameters other than gait? What is the call on this from the panel now? Is it only the gait, or some other clinical parameters are there other than RO, which was being mentioned of 18 mm and all? Not everybody would be doing the measurement. So do we have any well-established clinical parameters which would be an indicator of successful CSF diversion procedure, whatever we may follow?
Thanks, Daljit, for this question. I think the gait disturbance, gait improvement is immediately seen almost after the TAP test. In the case of NPH, and it is most reliable for positive TAP test. And some people also use neuropsychological evaluation. Probably it needs a little bit of neuropsychologists and neurologists to do the test before and after the TAP test. I think
Sir,
Lakshmi Narasimhan will be able to
Is
elaborate on this.
there anything like finger tapping test, or going up and going down, speed of walking, the stance other than walk alone? how reliable are those also in making clinical decisions?
So most of the tests have a sensitivity of around 60 and around the specificity around 56. So the most of these tests, post TAP assessment tests, whatever is right now available, have a very low specificity and a low sensitivity, sir. They don't, most often it is going to be clinical assessment only. But what I'm trying to say is now the paradigm is completely changing because of the development of gait labs and various gait kinematic metrics which have started, like step length, stride length, the step height, and all those minor parameters. And what they have done, what they are trying to do is a lot of research is going on gait kinematics post lumbar tap. They are
Yes.
trying to even use AI. They give data for AI to predict whether the shunt will be useful or not, sir. They are giving almost 13 to 15 parameters of gait into gait metrics into the system, and then ask this AI to predict whether shunt is going to be beneficial. If so, how long? How long the shunt will be beneficial? All this the AI is trying to predict. They are using a SVM, sir, support vector machine network, which they are doing, which I felt what is a primitive network, sir. But what they should do is we have to go in for a higher AI, like a convolutional network, or this is the most. I would prefer the convolutional neural network because it is very robust in interpretations. So the more and more data which it gives, it will be biologically inspired to give us better. And otherwise, the clinical judgment is now, as on date, it is superior than most of the post TAP tests which we use, sir.
Okay.
Sir,
What about
you are a neurologist, sir. Sorry, sir. I want to just interfering. Sir, are we no more using the mini mental scoring just before TAP and after TAP?
Sir, they don't change so rapidly.
yes?
They don't change, sir. Actually,
Yes.
the even the individual domain specific tests after 48 hours have not shown significant changes.
Sir, Lakshmi Narasimhan, sir.
But importantly, you will see the subjective feeling of betterness, sir. The patient saying that I feel better after the test, which is, if you think even though it's not, I don't think it's a placebo effect. Most of the patients, they tell clearly whether they become better or not, sir. When you ask them.
Do you do an elaborate neuropsychological testing?
Yes,
for
sir.
any
We use a clinical psychometry for 5 domains. We do all the tests, but I found them that they are not that useful to make a decision.
Okay, suppose, have you come across at least some patients who have had a major increase in their, have had a major step up in their neuropsychological function after a shunt? There is a small subset who tend to have a significant amount of dementia, but this also seems to improve. Have you come across some of these?
Yes,
patients?
sir. There is a subset of patients who are dramatically improve in their cognition and gait both. I have seen the subset, but we have not yet fully understood that's what I feel. It's still a long way to go. I have definitely seen at least 3-4 patients who are dramatically improved. A patient was an ambassador for a country, not able to function, not even forgot driving and all these things. She had so much completely reversed back to work following shunt. I feel that that kind of, we don't know. I'm not. I wouldn't apply that scale to everybody, but there are definitely a subset of patients who improve dramatically.
Actually, to predict, good response to shunt, the gait disturbance should be predominant.
Yes,
Dementia should be very subtle. Should not be very gross. Very gross dementia, they don't do well with the shunt. And our outflow resistance measurement is definitely very useful tool. I have been using it regularly, and I have been able to have good results based on that. We have a high outflow resistance, we have good shunt responsiveness, and good results following shunt. And the only thing is, initially it may find it difficult, but once you start doing it, it's very simple method. It takes hardly 15 minutes to do that, and does not require any sophisticated setup. I think I would suggest in case of, I mean, you have a doubtful diagnosis, you have the important tool of outflow resistance measurement.
Sir,
I just want to add one thing. I just want to add one thing. Sir, what I feel more than the severity of dementia, the onset rapidly deteriorating short-term cognitive deficits are first one is a gait, as Professor VGR said. Gait is the more important one to assess. The second important parameter is if the patient had very sudden onset deterioration of the cognitive functions rapidly, those kind of they were only the people who they really benefited from that, not the long duration ones.
The Ramesh sir, suppose
Dr. Bhartiya, Dr. Bhartiya is saying
Yes.
something, trying to say.
Yeah, I think it was very elaborated presentation by Professor Lakshmi and Professor Ramesh. I just want to know that these are all very elaborated theoretical talks. So the practical talk still remains about the gait taping and the memory. So because the differential diagnosis Professor Lakshmi has mentioned, even if you do the tapping, that may not give you the correct diagnosis. So in practical the practice, what would you recommend? And it is always we say for every problem that it is long way and we have to go for further research and this. We have been going long way already 40 years. How long we have to go for to come to a conclusion? Because we have seen changing shunts, changing treatment we have seen. The instrumentations have been changing. The pharmacy has been changing, the instruments is changing, but the pathophysiology still we have not been able to understand and manage. So what would you suggest in practicality for the diagnosis and for the treatment as such? Just the tap test is the you can say the main pillar of the diagnosis, or what is the main pillar of the diagnosis?
The main pillar is still the clinical, as Lakshmi has told. Clinical diagnosis is the most clinical important, supported by the radiological features. And of course, when you have still a doubt or something, the tap test is a very useful and easily performable test, and you can do that. But in certain cases, still we have doubt in diagnosis where this outflow resistance measurement helps. I
Yes.
think most of the cases you go up to tap test, it is enough to diagnose NPH most of the time.
Because when we see in practicality, when we see patients with so much of cortical atrophy and dementia also, and they have some periventricular lucencies also. So what
Yeah.
we fall back upon is the tap test.
Yeah.
Still in those patients also we do a tap test and see for if there is any improvement in them. And then we, with the neurologist consultation also, then you plan for treatment. So I think that remains the hallmark of all the problem. Dr. Daljit is there?
Yeah, he was here. He was here only.
Rajit is there. I think
Will there be
Ramesh sir.
will there be not any fundus changes or papilledema or something like in that if it is a chronic normal pressure hydrocephalus line?
We have not seen, I think, fundus changes in
Sir,
normal pressure hydrocephalus.
Yes,
Because it
sir,
is a normal pressure, so the fundus, there won't be any changes. Professor Lakshmi would be able to tell better.
Yeah.
Sir, normally there are no fundus changes, sir. But now they are trying to, what they are trying to do is, they are now trying to do the optical coherence tomography and try to see whether there is any fiber dropout because of the hydrocephalus. And they are also trying to measure the retinal nerve fiber layer thickness. There is any difference, but as it is, for a gross fundus examination is normal because the pressure is normal, sir.
And if we do perimetry?
So perimetry also there's no visual field defects. You don't see any visual field defects.
There is no enlargement of the blind spot or anything else like that?
No, sir. No. They all go
So-
against the diagnosis of idiopathic normal pressure hydrocephalus.
Okay.
They all fundus changes or enlarged blind spots or field defects all go against. You must go flat out to find out there is any obstruction anywhere in the CSF pathway.
Okay. Thank you, sir. Thank you.
Mr. Ramesh, sir, suppose, do you think there is any risk in doing the bolus infusion test to check the resistance? Any risk of herniation or neurological deterioration?
Usually it doesn't happen. I mean, it's only communicating hydrocephalus. Most of NPH is communicating hydrocephalus. There is no risk of herniation.
Communicating. Suppose there is a borderline case where you have a small whether there is an element of
No, if there is
obstruction
obstructive
also,
hydrocephalus, I think
absorptive
you
failure.
should not do. Obstructive hydrocephalus you should not do, but most of the NPH
Okay.
is mainly
So,
communicating hydrocephalus.
So, but sir, you showed the MRI where the aqueductal, there was a flow wide in aqueduct of
Yes.
the CSF. So that shows there is a high pressure coming from the third ventricle to the fourth ventricle.
Yeah.
So we can assume that this is the finding of actually aqueductal stenosis. So where the diagnosis changes from the NPS to like obstructive hydrocephalus or partially obstructive hydrocephalus.
No, this only indicates the flow velocity across the aqueduct is more because of the stagnation and this thing, but it does not indicate there is obstruction. It is not
So no,
indicative
if the flow void is there, if there is a high flow, it means the
high flow is there because of the stagnation of the CSF and obstruction to the absorption.
Dr.
Because of
Bhartiya, what you
stagnation.
say, if in these cases where you see the flow voids in aqueduct, does the ETV works?
No, actually, it's if it is there, it is a diagnostic, but it is not. Contraindication for doing a tap test or.
No, but if in these cases, my question is to Dr. Bhartiya, does the endoscopic third ventriculostomy works here or not?
It works in 50% of the cases.
So how would you predict that in which patient you have to do shunt and which patient you
See, whenever we are doing ETV, there are very fixed criteria also for doing ETV. They have been recommended for various types of problems. And in none of them you can predict, like age of the patient or the etiology and whether there was hemorrhage or not or whatever. So the percentage of it is in the different studies have been given. The like age of the patient, if it is less than 6 months or so, and 20% only, 80%.
No, that is a different
Similarly,
criteria. That is a different criteria. I just talk about the aqueductal flow, where there is a flow void in a clinically diagnosed patient of NPH. And if you see the MRI with the CSF dynamics, the CSF flow is very high at the aqueduct. I have done ETV in some of the patients, and I have seen the stoma at the third ventricle. There is the same flow void occurs after when the third stoma is patent, and the flow void at the aqueduct reduces.
So the patient improves.
The patient improves gradually on clinically. Yes.
Yeah, patient improves, but then in which patient it will work and it will not work is not possible because you do not know the absorption from the arachnoid villi on the top of it. You see, so that also counts. The CSF circulation has, in toto, we have to take into the consideration, and therefore the results in normal pressure hydrocephalus, if you do ETV, are said to be 50-50. In some it works, in which it will work, I don't think. Maybe Professor Matthew may be able to guide us something more, or Daljit, if he is there, he would be able to tell us better.
Sir, I had a question for Bharatiya sir. Sir, do you think we must do a programmable shunt, which is rather than a simple shunt for a patient with NPH?
I think.
Sir, you have gone mute.
Dr. Bhartiya is
Your
not
phone
heard.
Sir, Bhartiya sir.
You have to unmute yourself, Dr. Hemant.
Sir,
Okay, you are okay. Can you hear me now?
Yeah.
you are audible now, sir.
Yes, yes.
Yeah, the programmable shunt is now the choice of the shunts which are available, because you can always means monitor the pressure, and you can change the pressure depending on the patient's clinical condition and if there are any problems you face. So that remains, because of the otherwise also you would not know in other shunts which we use how much is the means CSF draining, not draining, and what is required uh, unless clinically it is done. Well,
Sir, I had a question. Yes, sir.
no, what other?
Ramesh, sir, suppose you are finding, Ramesh, sir,
Yeah.
suppose you are finding a very low pressure. You have something like when you do a tap test, you find a very low pressure, but the patient has clinically improved. What type of a shunt will you put? Will you put a low pressure shunt, or will you go for a medium pressure or a high pressure?
I usually in NPH I put only low pressure. I don't put medium pressure most of the time. I mean, I have used only low pressure shunts. And if I have not experienced with, programmable shunt, but I usually prefer a low pressure because the CSF pressure is never very high to drain in median pressure. So I think always it is low pressure only.
This one, suppose, Ramesh, sir, you get a patient who has dominant dementia and no or very little gait problem, but all other features, including your tap test, the compliance test with a bolus, is showing a reduced compliance. Do you think we should go ahead with the shunt? Only dementia.
Only dementia, I won't do a shunt first. If it is, especially if it is showing low operating pressure and low outflow resistance, probably I would not do a shunt.
VGR sir.
Yeah.
You said that you put low pressure shunt. I think some people may misunderstand this nomenclature, because low pressure means when the pressure is lower
low
than 40
operating
millimeter
pressure
of mercury, it will drain. And when the pressure is high only, then it will drain. Then it is called high pressure. When we use it is a low pressure hydrocephalus, then we use high pressure shunt, which opens only after some. If it is a very low pressure, then it will drain more.
Actually, low pressure normally we say it's because who has a low opening pressure, which drains with the low pressure itself. High pressure is usually which drains after the pressure is very high, like more than 15 or 20 millimeters of mercury.
That is medium pressure, also same in the same theory.
See, this nomenclature which Dr. Bansal is saying is really and has been really very confusing for many years. The low pressure, medium pressure, and high pressure. Then there are HDR, MDR, and LDR. Low discharge rate, high discharge rate, and medium discharge rate.
That is the correct. That is the correct
Now you
method.
have to correlate two things: the discharge rate and the pressure rate. So if it is low discharge rate, means low discharge means when there is a high pressure, you want low pressure discharge rate.
Yeah,
When there is low pressure, then you want high discharge rate. So when he is saying low discharge, low pressure shunts used, so usually it is the low pressure which is used in normal pressure hydrocephalus, means the discharge rate would be higher in those patients. So that is the nomenclature was confusing. You are very right, but Dr. Bansal, this is that confused.
Thank you, sir. Matthew, can we?
I have noticed that Dr. Dhaval Shukla has joined.
Can we ask in between the participants to prepare questions to ask
Yeah.
the
We can,
speakers?
the participants are all free to ask questions. They can put in the chat box or they can actually directly ask also. Till now, no questions have come in the chat box. Dr. Dhaval Shukla has joined. Maybe I can invite him to give his talk on treatment of NPH and NPH. Dhaval Shukla is currently head of the Department of Neurosurgery in NIMHANS, Bangalore. A great friend of mine for more than 2 decades. He is currently head of the department in, the NIMHANS now. His fields of specialization are vascular surgery, endoscopic pituitary surgery, particularly for functional adenomas. He's a remarkably skilled intraventricular surgeon. He's a great academician. He's extensively published and is a highly practical and down-to-earth person. Over to you, Dhaval, to talk on management of normal pressure hydrocephalus. Dr. Dhaval, your slide is visible.
Hello, am I audible now?
Yeah, you're visible. You're audible. You can speak up.
Yeah, I was hearing your discussion very quietly and silently after logging in. I don't think I have anything left now to contribute, but for sake of completion, I will. So, treatment is not only surgical, there is something called medical management. So this medical management for all patients we know, either you can modulate the CSF production, that is enhance drainage or decrease production. Like we can enhance CSF drainage using conventionally used osmotic gradients like mannitol, glycerol, and some diuretics also. Though they are really useful in cases of high pressure, so-called high pressure hydrocephalus, or maybe high volume hydrocephalus, like in choroid plexus hypertrophy, choroid plexus papilloma. We can enhance the drainage, or we can even reduce the production acetazolamide. So, but this strategy largely does not work in normal pressure hydrocephalus. But yes, people do adopt one of these medical therapies for normal pressure hydrocephalus because diagnosis may not be certain, and one may be skeptical directly proceeding with a shunt, which has its own complications. So surgical management, shunt is treatment of choice in NPH. There is no doubt about it. So whatever new treatment comes, that will be compared with the shunt. And shunt surgery improves symptoms in 60%. Some people say even 70, 75%. And shunt can be placed anywhere from ventricle or lumbar to atrial or peritoneal. However, commonly preferred is ventriculoperitoneal shunt. So it is not only for NPH, but even for post-SH hydrocephalus, when you have to do shunt, though both are like communicating hydrocephalus, it is always preferred to do ventriculoperitoneal shunt rather than doing a lumboperitoneal shunt. So VA shunt, there are few people who still do VA shunt, and as far as effectiveness is concerned, it's not different. But only problem is shunt nephrosis or nephrotic syndrome, and it may be preferred when there are intraperitoneal lesions, because this disease occurs in elderly people. So by the time they are 60, 70, or sometimes now even 80s, in India also people are living till 80s. They would have undergone one or the other abdominal surgery by the time they have survived so long. So peritoneal may not be suitable, and if you experience ventriculoatrial shunt, it's a good option. I heard about ETV. So ETV is like swinging pendulum. Like from 2003-4 papers are coming on ETV is useful, not useful, and people who feel it is useful, they publish high success rate. People who feel it is not useful, they do not publish their low success rate or failure rates. So people get prejudiced doing ETV. So most important thing is, before asking for ETV or offering ETV, is to look for an entity called LOVA, LOVA, that is late onset ventriculomegaly in adults, which grossly, when you do MRI, grossly looks more or less like idiopathic normal pressure hydrocephalus. And remember, this late onset ventriculomegaly also occurs in adult and elderly. So there may not be classical aqueductal stenosis sign which you see in small children or young adults like periventricular seepage, classical triventriculomegaly, and all those things. So when you do a high resolution MRI 3D image, and you will be able to find one web in the aqueduct. So there may not be long segment stenosis, which will be overtly visible, but there will be just a web. And if you miss that web on routine T2 weighted sequences, you feel it is a communicating hydrocephalus, like third, fourth ventricle is not so big, but all ventricles are dilated. Fourth ventricle may be dilated independently also because of cerebral atrophy and all. So you may just offer shunt to all such patients. But when you see an aqueductal web, it is an aqueductal stenosis and it is a late onset ventriculomegaly. And such patients definitely benefit with endoscopic third ventriculostomy. And ETV should be considered as first treatment in such patient. And as far as other CSF outflow resistance studies and all, like if there is a high CSF outflow resistance and all, and low lumbar CSF outflow resistance, one may offer ETV, but that is not a very good predictor whether ETV will be working or not. Like Dr. Bhartia said, 50% of the cases it works, 50% of the cases. So it is like tossing a coin. You want ETV or don't want ETV. We don't do such things in practice, right? When we have confidence that one treatment is going to work in 60% or more of patients, we are likely to offer that treatment rather than the treatment which works or does not work in equal proportion of patients. So the papers proponents of ETV as recent as 2022, the systematic review and meta-analysis showed that there was not much difference between ETV and VP shunt. Our ETV had lower complication rate because obviously VP shunt, you are putting a foreign body, there is a risk of infection, risk of migration, risk of blockage, risk of mechanical damage. So ETV may be better. But again, all this systematic review and meta-analysis, they have not identified, like it is not matched properly. Like, is it really classical INPH or there were some lower cases in ETV group and all those things? We don't know. So ETV may be offered, but cannot be offered as prima facie against VP shunt. So whatever you do, ETV or VP shunt, CSF diversion is not without complication. Like common complication, we all know subdural hematoma, shunt infection, seizure, shunt malfunction. Particularly, I would like to bring you to notice subdural hematoma. Like when you do shunts in young adults or children with brain tumor and hydrocephalus, you don't see subdural hematoma. But when you do shunts in very small children with thin cortical mental, you see subdural hematoma, and sometimes they get even calcified. So same analogy applies in very elderly man with a lot of cerebral atrophy. In infants, it is thin cortical mental. In elderly, it is cerebral atrophy. But amount of brain matter is less in both the cases. Hence, both this population is vulnerable to develop subdural hematoma. So when it comes to whether comparing VP shunt, VA shunt, or lumboperitoneal shunt, looking for there is not much difference in the incidence of subdural collections. Like one may presume that lumboperitoneal shunts may cause more subdural collection as compared to ventriculoperitoneal shunts, but that is not the case. And same thing is about infection, irrespective of type of shunt, the infection rates are also more or less same. So now the questions which was discussed, the type of valve or type of setting the selection. So as I gave analogy of thin cortical mental in infant, same analogy in elderly. So if you put a fixed pressure valve, whatever you may call the term high pressure, low pressure, medium pressure, there is nothing to do anything after you put a valve. You cannot do anything further. Whatever pressure valve you have put. So there will be risk. So there are differential pressure valves available. There are pressure valves with gravity compensating device, and the flow limiting valves are also available. Now, simple differential pressure valves, they just open when there is a pressure gradient, and again there's low pressure, medium pressure. There are cutoffs for each one of them. However, low pressure valve, as I heard during discussion, somebody told that we may prefer to put a low pressure valve, but there is a risk of over drainage. The anti-siphon devices are good because once you put a valve, the Even if there is a wall, it will not prevent entire PSF drainage. So anti-siphon device can prevent, and they are effective in preventing postural intracranial hypotension. Like when the person is upright, a lot of drainage can occur. Even if you adjust the pressure, still drainage can occur. So anti-siphon device, they contract the gravity-dependent drainage, like they are called ESDs, and there are various companies. I do not have any conflicts of interest with any of these companies. And we choose what is available in government hospital in that particular year. It's not necessary that every time we have used Medtronic or every time Codman. Some 2-3 years supply will be of Codman, 2-3 years of Medtronic, and so on. So there is no particular preference to use any one company valves. Then flow limiting valves, like you say, just have some amount of fixed amount of it should flow irrespective of pressure. So flow limiting valves, according to fluid mechanics, sounds good. But one problem with all this flow limiting valves, there are various companies which manufacture flow limiting valves, that they are highly vulnerable to blockage, which we classically see in not only in shunts, but even in EVD, urinary catheter or drains. When there is not much flow across the drainage system, the drainage system gets blocked. The same analogy applies when it is just flow-based valve, it is vulnerable to block easily. But then there are dual stage differential pressure valve design. So they have got like dual switch. So these are not purely adjustable, but you can like switch to one pressure to another pressure like that. But that popular are adjustable programmable valves, which has multiple levels of programming can be done and multiple levels of pressure settings can be used. Again, a number of companies, but major drawback is cost. And earlier there were issues about MR compatibility, but nowadays the newer versions are all MR compatible. So there is no issue using newer programmable valves. However, there is bias in identifying shunt malfunction, like whether it is pressure is not good, that's why shunt malfunction has occurred, or there is true mechanical blockage, so there will be bias. So this is a strata. This is a design of the strata valve from Medtronic. This is from Codman. So choosing that differential pressure valve with anti-siphon device or without anti-siphon device. So these are the scores of improvement. So relatively better, but not significantly different. So logically speaking, anti-siphon device is good, better, but when it comes to evidence, it has not shown significant difference, whether you add an anti-siphon device to differential pressure valve or not. Again, differential pressure valve versus anti-siphon device. So without anti-siphon device, there is increased risk of CSF drainage, over drainage. But again, statistically, it was not very great. Same thing comes using other disability score like MRS. MRS is basically a score of ambulation. And again, though there is some difference, but it is not statistically significant. So this is systematic review on programmable shunt valves for treatment of hydrocephalus. And in that, they showed that there is a risk of over or under drainage in patients who receive fixed pressure valve as compared to differential valves. So this is a comparison of the cost, like being a government hospital with limited funding available. This is the cost at which we get. So you can see there is not much difference. But if inline lumboperitoneal shunt valve system is actually more expensive than the ventriculoperitoneal shunt system. So at NIMHANS, we have done quite a few cases, and most of the time it was ventriculoperitoneal shunt, and on a few occasions thecoperitoneal shunt also we have put. So when it comes to ventriculoperitoneal shunt, most of the time it was programmable shunt, like more than 50% of the cases. In very few cases, we have put non-programmable shunt. And in lumbar shunt also, we have put occasionally programmable shunt. But again, now the programmable lumbar shunt, again, it became unavailable, so we stopped using it. So this is the commonest shunt system which we use. And it has got in 18 steps you can increase or decrease the pressure right from 30 millimeter mercury to 200 millimeter of mercury. So this is the manual. I think once you put a shunt, the manufacturer will give this manual and you can adjust accordingly. So the most important is the position of, you can see with X-ray also the position and can know what is the value. So you need to open and see from outside also you can make out the value. So this is the guide which will tell you at what pressure the currently shunt system is working. So only important thing is the position of the head should be correct. But if the position of the head is not correct, the radiograph will be false reading and you may try to over adjust. But this is Medtronic Strata shunt valve design. And again, you can see in lying down and standing position, the pressure changes. So this also we have used earlier. So this you already told, all of you have told that gait is just something which shows markable improvement, whereas cognitive improvement is not so great, and urinary incontinence improvement is also not as great. But gait, now why we are targeting only at gait? Like gait is like there are two things which are very disabling in neurology. Like one is ability to move oneself and ability to feed oneself. So if a person is able to move himself or herself independently, significantly reduces the burden on the caretaker. So gait improvement is of real clinical significance. Though cognitive is also significant, but most of this patient, elderly patients, they might not be actively working and it may not make much difference to the caretaker as they are already used to taking care of them at home. But only thing they want them to be up and about. So one thing you should remember that a person who gets normal pressure hydrocephalus is not immune from getting any other neurodegenerative disorder. So this is one such case which we encountered recently. This person had classical features of INPH, all this step, whatever test you people told, everything was done and everybody was convinced and the shunt was done. Programmable ventricular peritoneal shunt was done. And 1 year he had remarkable improvement. They were relatives were very happy. And after 1 year, he started rapid deterioration, rapid neurological deterioration. So he was obviously unhappy with the first surgeon. So they went to another surgeon. So he put a new shunt. Again, new programmable shunt. N number of times programming was changed, but patient had rapid neurological deterioration. Then we refer to neurologist, and it shows that PET MRI shows significant hypometabolism, frontoparietal region. So he has developed a new disease. Dementia is developed, which is rapidly progressive. And doing shunt, changing the pressure, changing the shunt is not going to help. So you should very clearly counsel the patients that there can be overlap of both NPH and AD, NPH and FTD, and only the gait component may improve. And if there is a combination of both AD and NPH, down the line, patient will show the symptoms of AD, that is Alzheimer's disease, and will deteriorate in spite of very well functioning shunt and in spite of walking very well. So these are the Japanese guidelines. I think all the residents who are attending, they can just download the Japanese Society guidelines for normal pressure hydrocephalus. So this is in summary what we do. So at least one symptom in gait, urination, and cognitive domain should be there. And no causative neurological or neurological disorders. Now here comes no causative neurological or neurological disorders. So there are people who will still offer shunt even if there is dual neurological disease like NPH plus AD. But Japanese are very strict. If AD is also there and NPH is also there, they will not do shunt. We also are very strict in choosing our patient. Like if patient has overlap disease, our tendency is not to do shunt rather than to do shunt. So it's individual philosophy. But there should not be another preceding cause of hydrocephalus, and age should be 60 years or older. There should ventricle should be dilated, advanced index should be more. Then it says there is a possible INPH. Then the features, other features are tight, high convexity, and medial subarachnoid spaces and enlarged Sylvian fissure. This helps to dilate subarachnoid spaces. So, and look for the gait. If gait is ataxic or epileptic, there is no change, then tap test and lumbar puncture you can do. Again, now controversy is whether you should do one lumbar puncture, you should do 3 consecutive days, or you should put a lumbar drain for 3 consecutive days before you tell that CSF diversion is not going to be useful. So you go for second level, and then you do shunt. If shunt is working, nothing to worry. If not working, then check the patency and set the valve gradually at lower pressure, and then or revise the shunt. And then if we respond, so actually, truly speaking, the diagnosis of INPH is in retrospect. It's never in prospect. A person who has responded very well to shunt probably had diagnosis of INPH. It is not other way around. And if it does not respond to shunt, then as I showed you one case, reconsider the differential diagnosis. Or possibly he had NPH, he responded, now he has stopped responding, so there may be some other diagnosis. So concluding, NPH is an extremely disabling condition and it is a clinical diagnosis, we should remember. And symptoms can be reversed to a significant level by early diagnosis and appropriate treatment, and timely intervention with shunt leads to favorable outcome. At the same time, you should guard that not all patients benefit, and patients who not benefit, they should undergo re-evaluation for other causes of dementia. That's all I want to say.
Hello.
Hello. Hello.
Yes.
Yeah.
I think Dr. Dhaval has covered the management part very well. I have two things in contradiction with Professor Dhaval. May not be contradict, but maybe that philosophy difference, that when you said that there are no means if it is only 50% improvement with ETV, and with shunt if it is more than 70, 60, 70%, you would go for shunt and not give a trial of ETV. We in practice work little different, I think. If it is even 50% improvement with ETV, I would rather avoid shunt at the first go and put a foreign body, and maybe that will give a trial of if ETV works. That is the best thing to do. And second point, you said that if the patient has two disease, normal pressure and the dementia, and suppose if the patient improves with the tap, lumbar tap, suppose, then will you still not consider putting in a shunt, or let him go with the dementia only and suffer with both the diseases, or will you do a shunt in them also?
Dhaval? Dhaval?
Dr. Dhaval?
Have you gone, Dhaval?
Professor
Dhaval has lost.
Professor Matthew, what will you do? Or Dr. Daljeet is also there.
Yeah,
He
we
can
certainly.
Yeah. It's a
my
very good question. I tell you, this is very, very good question indeed. You know, about a year ago, I reviewed extensively on NPH, and I was pleasantly surprised that neurosurgery had taken out two special issues on NPH. Whole issues were there on and general. I mean, not general. It's a neurosurgery in itself. So I was pleasantly happy to see that the description that coexistence of dementia, NPH, and some of the other conditions do exist in as much as 70% of these patients. So what Hemant was trying to say, that if dementia, he goes with the dementia and is benefited of the components of the NPH, yes, it should be given the benefit also, provided we are able to equate the components very effectively in our analysis, neurological, clinical evaluations, maybe with the help of some of the neurotransmitter biochemical parameters which are exclusively seen in dementia, thyopathies, and those things. And we are able to reach, look, I mean, a patient has a mixed combination of so many things, and only this fraction is likely to improve rather than totally giving it up. Now, I fully agree. Now, another comment which I thought I'll share in between was ETV, which Hemant said. Hemant, I have done extensively. We had a thesis also on ETV. Okay. Our results were not very good in NPH patient with ETV. I had no reason to explain. Now, maybe our case selections were wrong, and I was wondering, is there a difference of ETV in a patient of NPH versus patient of classical aqueductal stenosis? So, when I was reviewing some time back, we discovered that in patients of normal pressure hydrocephalus, there is an element of physiological aqueductal stenosis which can be seen in cine mode MRI on the CSF rather than coming from caudal to cranial to caudal. There's a reflex from caudal to cranial in some of the CSF sequences, and which, if present radiologically, is an indicator of a successful diversion, including ETV. So there was a hint in the radio imaging, such patient may benefit in ETV if you have a demonstrable aqueductal stenosis, even if it is physiological in cine mode MRI, versus those patients who do not have, they would do better with the VP shunt or VA shunt or LP shunt, whichever methodology one would like to take in a particular patient. That is what my understanding was about the subject. Now, we also take into consideration callosal marginal angle, fish index. Sometime it may help us in making decisions, likely prognosis in these patients. Yet, I think one may fault in our clinical assessment. There may be something which is still not fully understood in NPH. We move on what we know with the current knowledge, and I think we all would modify. So I just wanted to know why you were so clear about ETV should be given a chance unless we have some more understanding in terms of technical or physiological aspect of ETV.
The personal experience, although not very high as yours, but
Yes.
the number of cases I have done, I found in 50% improvement, plus the literature which was there before, which most of the people and most of the series quote that there is a improvement in 50%. That's why I said. And
Yeah, I agree.
your observation, we all respect your observation, and must be that uh, uh, maybe that the shunt is the first choice then.
Dhaval has already joined again now. And Dhaval has started saying in the beginning that the patients who did not respond well with the study in which they have they failed the ETV, they do not publish. So the publication is only when these patients they get benefited in that study. They only publish. Otherwise, they do not publish. That is one thing. And the second thing again, the Dr. Vijay also shown and the Dhaval also said that if there is an aqueductal flow or there is an aqueductal web, then ETV will definitely work. If we have a radiological imaging which supports that the CSF diversion will work, then it is always work. Yes, Daljit sir.
Yeah, I think we're talking on the same line. Okay, today if you ask me which patient of NPH I would go for ETV, plainly I'll say I'll try for every patient. Okay.
No,
Fine.
no,
Plain,
no.
no. Please let me complete. So plainly, I will say in everything. On face of it, if I believe 30, 40, 50% of them. Now you are talking of web. I'm talking of physiological obstruction in a cine mode MRI, which is
Yes,
different from the routine MRI. I just mentioned
yes,
about that.
yes,
So
yes,
cine
yes.
mode MRI would give you the flow of from the aqueduct, which I am repeating. It is now evidence is accumulating that even in patient of an NPH, there is an element of aqueductal stenosis. It
Yes,
may
sir.
be a
Yes.
web, it may be poor physiological obstruction, maybe at the level of foramen of Magendie and Leschko also. Okay, there has been old some subtle infection or some SAH or some bleed, some metabolic cause. They may also produce some kind of a cicatrix in the outlet of CSF drainage. So if we can identify those patients, RO value, LP value, which Dr. Ramesh said is directly related to rise in RO values, indication of a poor flow from the aqueduct to spinal canal, that only then the RO values resistance will increase, not otherwise. Okay, so they are interrelated. Now, yet saying despite discussion, the clarity, I think most of us still rely upon the gate. Okay, and in the gate, there are parameters of improvement. And I'm forgetting the classifications which talk about gate classifications of 2, 3 different type. There are various classifications now available, scoring system for NPH also, and predicting the outcome with any of the draining procedure. They are existing. But then ETB is not completely out. It does have a role, provided we I'm again repeating, is there a difference of doing ETV in a normal aqueductal stenosis vis-a-vis NPH patient? Okay. The, do we need to have a larger stoma in a patient of uh, NPH versus a patient of classical aqueductal stenosis? Hemant, do you have anything to talk about that?
See, the stoma, why you are saying is because of the pressure itself. The
Yes.
and the obliteration of the stoma. These are the two things which matter. So, if it is a larger stoma, then it may drain more of CSF, even if it is a not very high pressure. This we may
True.
take it
True.
like that.
True.
That is why the larger and the chances of its obstruction are less as compared to narrow stoma. So
Yes.
that is a better thing in cases of NPH. But in
Yes.
cases of aqueductal stenosis, definitely if a moderate size stoma is there, the pressure
It's
would be
good
high.
enough. Good enough.
So
It will
that
keep working.
keep working. That's it.
Yes. That's it. Absolutely.
Regarding Hemant Bhartiya's comment about question about overlap disease with element of dementia and a gait problem, I just had a point to add. Most of these dementia patients will have some improvement after your shunt. But there's one very practical problem that will come when you treat a dementia patient. Even a small UTI or a small upper respiratory tract infection will make them look like they are comatose. They are very flimsy patients. Even the smallest lateral problem will make them very sick. So once you have
Yes.
done a shunt, the entire burden of the future illness will actually come on the neurosurgeon. Because these are all lateral events, but cannot be comprehended by a usual bystander or usual patient. This is one practical problem in tackling the dementia patient, even if they show some transient improvement. Once you commit on it, the the uh, the everybody will start trusting on the shunt, and the fancy will be to change its pressure each time. Dr. Dhawan?
Matthew, can you repeat what you said in the last? Once you suspect dementia, what?
Yeah. Once you have suspected dementia, the moment you do a shunt, the whole
Yeah.
responsibility of looking after the patient to some degree come on you. Most of these dementia patients are very flimsy when it comes to their day-to-day issues. Even a small UTI, even a small upper respiratory tract infection will make them behave like they are comatose. You will find them lying in the ICU in a flaccid state for a whole couple of weeks. And the whole issue comes whether you have created some infection or whether your shunt is malfunctioning, and all these things come. So the problem of keeping away from a progressive dementia is of great importance to a neurosurgeon. You will waste a lot of your time. You will find a lot of socially awkward situations when you do that.
Okay.
And
So
Dhaval,
I just want,
yeah.
yeah, let me have the panel's opinion now. How many tap should be done before saying this patient is unlikely to remove? What is a normal practice at your end? Suppose first tap test is negative. When you do second tap test, and if that is also negative, to say when should we do the third tap test, provided we drain the same amount of the CSF every time?
I think in consultation with the neurologist, we have been doing 3 taps, and
How
they
often?
after 48 hours or 72 hours of gap, maybe 72, 48 to 72 hours, you have to give time.
Okay, so you were saying one should go for second or third before before deciding if patient is not likely to show any
If,
positive result within. Okay, what about
even
Dhaval? What
even
is
if
your take
you
on that?
even if it is positive, sorry, after the first test, you do a second also to confirm that yes, the patient,
So
even if we,
you are saying even if it is positive in the first, one should do second test. Okay, that's
yes,
interesting narration. Dhaval, what's your call in then? And I'll seek other neurology wala also.
yeah,
So there is something called positive predictive value and negative predictive. So positive
Yes,
predictive is if patient improves, it's a positive predictor. If patient does not improve, whether he will definitely not improve following shunt is another questionable thing. So for that, there you will do second time. Now, when will you do that is again unsure. Next day, next to next day, 48 hours, 70 hours. That is that. And one more interesting observation which we had that patients don't improve immediately after your tap. Like you do lumbar puncture and you expect patient starts walking. So patients sometimes take time to improve. And as Dr. Matthew told, these elderly patients have a lot of fluctuations. So you cannot actually assess with single time. So we have seen patients who next day they show improvement and there will be very slow improvement. And most important predictor is deterioration again to the pre-tap level. That definitely indicates that patient benefited and the relatives themselves will tell, do tap once again, patient improved. So typically one elderly person in India will have half a dozen relatives. And if 3 are telling he is improved, 3 are not telling he is improved, take not improved. So whenever there is ambiguity, so they are the best people because they stay with the person. And whatever scores you tell, MMSE 1 point improvement, 2 point improvement, and that those 2 points improvement here, there are also a lot of fluctuation. Even if a normal elderly person, if you do 5 times MMSE, you are unlikely to get all 5 times same scores.
agreed.
So best judge is like the person who stays with the elderly man or woman and tell him to observe for 1 or 2 days after lumbar puncture before signing off. That's what we feel. And in some cases, our neurologists, when they have extensively worked up for all other causes of dementia, they will insist to us to put lumbar drain for 3 days, which we have done very, very occasionally, but yes, we have done. And we have seen in those very occasional patients that after 3 days of continuous drainage, patient is sustained improvement. So those are occasional
Dhaval,
incidences.
there is
So let
a
me ask
question in
again,
the chat
what
box.
is your call on whether to repeat second in every case,
No,
even if the
no, no.
patient has improved in the first instant, or you
If
will not
patient improves
you,
first instance, we don't repeat. We don't repeat.
you you will go for the shunt.
Yes, 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 yes.
Okay, okay. Let's have the Matthew. What will your take?
Yeah,
What
there is
will you do?
yeah. I will, if there is a prompt improvement, I don't think we should do it again.
So there is
The
no
only
need to do it
aspect is,
again.
Sir,
the only
sir,
confusion is,
may I add something, sir?
Yeah,
yeah,
please,
May I add
yeah,
please.
Sir,
please.
in the first tap test, patient shows improvement. what we normally advise is you do a repeat examination, not a repeat tap again. But I would say the first stage improvement, we will normally repeat the cognitive test, all the tests again, and to see whether it is persisting, or if it returns back to normal. When the patient deteriorates before the previous step level, normally it clearly indicates the shunt will benefit him. So what we do is not the second tap, it's the second examination, the third examination. 3 subsequent examinations are important after a first tap before making any decisions. So that's what we follow, sir.
No, if the first examination is improvement, what is the objective of achieving the second examination? All
The second
patients
examination is
after some time will show deterioration.
No. The second test say that he say after a week, second or the third examination shows that he has returned back to the original level. Clearly means he will benefit from shunt, sir.
Okay. So you are saying deterioration in clinical condition is an indication for going for the procedure. Okay,
Yes, sir.
I got your
Improvement.
Yes.
Improvement
Got
followed
it,
by
got it.
back to
Makes sense.
original level clearly means he will
Fine,
improve it. Shunt.
fine. Dr. Ramesh.
Yeah, I have a little different take on this. I would like to agree with Dr. Dhaval that there is a deterioration to the previous level after initial improvement. That is a definite indication for shunt. But nowadays, what I do is I combine both the bolus infusion test with the tap test. So I mean, if both concur, the results of both concur, I definitely go in for a shunt. If both are equivocal, then I repeat it after a few weeks. I combine always tap test and the bolus infusion test.
Okay. Now see, why I asked this, we also had some very simple study at our institution a couple of years back, and I found, I mean, the policy is after second or third, depending upon improvement is happening or not, the success rate dipped from 90 to 60 to 30% on the clinical improvement after the shunt. If it was improvement after the first step, the clinical improvement following lumbar puncture, following VP shunt or drainage procedure was almost up to the tune of 90%. If the patient improved after second tap, it dipped to almost 60%. And if the patient showed improvement after the third tap, the success further dipped to around 30%. So, I mean, we also have something to add that it is just still, I think the first tap improvement is a better indicator of intervention than relying completely. I would also agree to that if the patient has started showing deterioration, it confirms that drainage had worked for a particular patient and we should move ahead rather than waiting. Second improvement, it will be certainly success rate will dip to almost half of the first improvement guide.
I just wanted to add a point. A single tap does not mean that the CSF leak, the CSF drainage ends at that point. Once you do a single tap, the CSF may continue to leak for several days into the subcutaneous space. So we really cannot predict whether it's just a single drainage, but it may be a continued effect of a flow or a drainage through the tap. So the doing on consecutive days is not actually a very objective method. Very often a single tap may be as effective as a repeated tap. I just had one question to Dr. Dhaval. What is your indication for a siphon device, for an anti-siphon device in an NTH patient?
Subdural. In spite of putting programmable shunt, if patient gets subdural.
Isn't it enough to change the pressure? For the anti-siphon device.
Right, that's what. Even after programmable shunt and using pressure adjustment, patient develops subdural, then anti-siphon device is used.
There is a problem with
patients like there are patients, Dr. Matthew, like you adjust pressure, they invariably develop subdural, whatever pressure settings you change. These are not very common instances. I am very sure that we have not done more than 2 or 3 times anti-siphon device. But there are people who develop like they are extremely vulnerable to develop subdural in spite of change in pressure. So anti-siphon, that is the only indication according to me of anti-siphon.
Okay, I just had to add a small thing. The anti-siphon device is actually a small metallic ball which changes to gravity. So the purpose of the anti-siphon device is to suddenly block the flow when you get up from a standing position. The ultimate effect of an anti-siphon device is the total flow through the shunt becomes a very small fragment. It may come down to almost maybe 1/3 or 1/4, because as long as the patient is in erect position, the shunt won't function. But it will prevent the headache. My question is, do you think the anti-siphon device can be a big disadvantage in an NPH patient? Because most of the throughout the day, when the patient is standing, the shunt won't work because the metal ball is gravitating downward.
Nice. So routine use of anti-siphon device is not recommended. It is an added. All of us forget about NPH. In many other hydrocephalus, there is a vulnerable population who develops symptomatic intracranial hypotension. Few people are more vulnerable to develop symptomatic intracranial hypotension as compared to asymptomatic. You see in post-op imaging, you will see signs of intracranial hypotension. But few patients are really sensitive and they develop more often. So for such patient, definitely anti-siphon device is used. Otherwise, the advantage of shunt goes away. We put a shunt so that they can walk. But moment they stand, they get headache and they don't walk. Yeah. So it becomes counterintuitive.
Yeah, your point is taken. We have one question. I think we have answered. Is continuous lumbar drainage better than a single tap? This question has come in the chat box.
Yeah, I mean, that is actually continuous lumbar drainage yields better results. But the only thing is, it's a little cumbersome. Patient needs hospitalization, and the side effects of sometimes the drainage is also there. So it is not very popular, but actually it is actually more accurate method of this thing than other CSF tap test. Continuous lumbar drainage is actually better than the single tap test.
Okay.
So,
is there any, Professor
Any
Daljit?
question? Sorry?
Professor
Yeah.
Daljit, yeah. Is there any means, what is the rationale of the patient after first tap improves by 90% with the shunt, and after the second tap, the improvement in only 60% of the patient? Why
I
is
actually
that?
don't have, yeah, I got your question. See, we do not have exact answer, but then, maybe, I mean, it is again theoretical extrapolations of that. The more symptoms are attributable to the large intraventricular volume of the CSF and the pressure effect because of that, and it started showing the result immediately. Okay. Subsequently, second test, maybe there is elements of other component of differential diagnosis of NPH which did not result in the improvement in the first go, and maybe they required little bit more amount of the CSF to be drained subsequently. Now in my place the practice is we drain one day, wait for a day, and after 24 hours we go for a second CSF drainage. We do not wait for a longer period of time. After one day we will go for drainage, because if the patient has shown improvement, some improvement is happening, I might wait. Then we observe the volume of the CSF which we have recommended to be drained, normally 30 or 40 ml. Sometime it shows better result if the volume is been more drained, like continuous lumbar drainage. Okay, it will be draining more amount of the volume on 3 days then actually the drainage of the one time volume which has been recommended in the literature of 30 to 40 or 50 ml. We will normally stop at 30 ml. Okay, that is what recommended classically. But then sometime I observe larger volume of drainage out of the CSF from the ventricular cavity possibly results in the recovery better than what is classically recommended. 30 ml, okay, fine. If it is still not showing and we have a very strong clinical and radiological evidence of NPH, maybe a little bit more volume drainage subsequently is facilitating the recovery. That is what my answer would be to those situations.
Thank you.
Right.
Okay.
I think we have had a very energetic discussion, elaborate discussion today. Since I don't find any more questions in the chat box, I think we can conclude today's section. Thank you all speakers and panelists for contributing so effectively. And thanks to my co-moderator also. Thank you very much.
Thank you.
Thank you.
Thank you.